Welcome to the Hawaii Parkinson Association's annual symposium. Everybody knows we've kind of moved around this year, moved around every year. We found this beautiful facility this year, which we wanted to give it a try. I think so far it's actually working out very well. A couple of our main guests are running a little bit late, so I'm going to be jumping around a little bit on my internal schedule. Hopefully it'll be transparent to you guys. But I wanted to take a couple minutes and recognize a few key people that are in attendance today. First, the Hawaii Parkinson Association Executive Board. I introduced myself. I'm Jerry Boster. I'm a 5-year Parkinson patient, and I was a young onset diagnosis. The Vice President, Kei Kitazuma. The Secretary, I'll get you to hold it at the end because I got a bunch of people to recognize real quick. And if we clap after everyone, we'll be here all day. Secretary Lindsay Sutton, and Lindsay is also the head of the newly created exercise committee. So basically, if anything it's doing with exercises, we're going to be running that through our exercise committee. Then we have Dennis Ideta. I think most of you probably know Dennis. He's our treasurer, been our treasurer for many years now. He's my mainstay of fountain knowledge. The rest of the board members at large from Oahu, Jill Wakabayashi. She may be outside still. She was running the registration table. Pat Bemis. There's Pat. For those of you who don't know Pat, she's now the fairy godmother of the patient and caregiver support groups. And she's also volunteered to put together a speakers committee so that we can put together a list of all the different speakers available to be used at the different support groups and other venues. I don't know if Dana Barbata, has she made it up yet? Oh, there she is. She's hobbling up the center from a skiing accident. From the Big Island, Joel Cohen and Fran Calvert. Fran and Joel both double as support group leaders on the Big Island as well. From Kauai, Jim White. I know Jim's here. I saw him somewhere in the back, or missed. But Jim also doubles as a support group. He was doing 2 support groups, but he just got somebody else to volunteer for the second one. Another group that I want to recognize is the support group leaders, who are such a key piece of what we do here in Hawaii. Russ Boyer and Nona Andrews from Hawaii Kai. They do a lot of stuff. Miss Jan from Mililani. I think everybody knows Jan, where she's running around here somewhere. Oh, in the back, all the way in the back. Typical Jan. Former HPA president Kevin Lockett, who runs downtown Honolulu. Kevin, I think most people know Kevin. I think he's actually running. Oh, you are inside. Great. I saw you walk by a minute ago outside, so I didn't see you sneak in. Dennis Miyamoto from the Windward Oahu. Dennis over here. Grant Lee, did you make it from the North Shore? Apparently not. Did you know if Skip Rush made it? He did not make it. He's on the North Shore of Kauai, starting up a group up in Princeville. So it's we weren't sure he wanted to come, but with all the challenges in Kauai. So for those folks, thanks you all that you do. You keep a lot of this organization running day in, day out, while some of us sit up top and think big thoughts and try to do big muscle movements. Lastly is the group of key people that we are all really endeared to is our medical professionals. I'm not sure how many of them made it into the room so far. Dr. Webb Ross. Webb, hey, I'm glad you are here, Webb. He's my mentor, my neurologist, and my friend. So for me, he's a key guy. Dr. Melvin Yee, you here, Doc? No. Dr. Stuart Peng is going to be joining us a little bit later. Dr. Bruno, Michiko Bruno, I think she may be running a little bit late too. Dr. Sarah Grainer, I know she's here somewhere. In the back, stand up please. I heard you're shy. You can't be shy in this group. Thank you very much. Brand new movement disorder specialists that just arrived on Oahu will very rapidly become part of our core group here. I saw Dr. Borman, Pat Borman. Thanks, Pat. Glad you made it. And then, of course, our keynote speaker for today, Professor Amy Lauer from the University of Hawaii. And I'll have a more in-depth introduction here in a couple minutes. The Hawaii Parkinson Association, I think most people know, has 3 key missions. We assist Parkinson patients their families and friends live the best life possible. We educate anybody and everybody who will listen to us, and we support research so we can work ourselves out of a job by hopefully finding a cure one day. So I wanted to briefly recap a couple of our accomplishments that we've done this year, because it's been a pretty busy year. Under the quality of life, we created a new patient support group up in Princeville, like I mentioned, created a new caregiver support group in Hawaii Kai and Waimea on the Big Island, working to create a new patient support group in Kapolei, hopefully get that up in your not too distant future, creating a new yoga exercise program that is also being tested in Hawaii Kai and Windward, Oahu. We're in the process of renewing the outstanding YMC exercise program that we've had for a number of years. We're working to refresh the DBS support groups and young onset support groups. And for these, when I say refresh, we're looking for volunteers to lead these. We really need some help there. And finally, even though we don't see a lot around here on legislation advocacy, we've had a couple wins this year. For those who are not aware of, when the budget was signed in, the therapy caps were removed for Medicare patients. Considering 80% of all Parkinson patients are on Medicare, that is a huge win for the Parkinson community. If you need more information on that, please let us know. Michael J. Fox has an article that I've got at home. I meant to print out a bunch today, I just ran out of time, that I can forward you that gives you a little more information. And then caregivers in general, passing more legislation both on the state and national level supporting the caregivers. We've done a lot for the patients, now we're trying to help out more of the caregivers. Education, I was trying to count up last night how many presentations we've done. I've guessed the people that do the speaking, we did somewhere over 30 presentations minimum in 2017 and early 2018. And we probably touched over 500 people. Tabling events, we had at least 10 tabling events, everything from the 2-hour small tabling event to the 3-day senior fair down to Blaisdell, which is a man killer. You can't even imagine how many thousands of people we affected there. Research, Hawaii Parkinson Association presented 2 $2,500 research grants last year. First one was to Dr. Webb Ross from the Pacific Health Research and Education Institute. The second one was Dr. Pat Borman from Hawaii Pacific Neuroscience. These funds go towards assisting patients from the outer islands to travel to the clinical research centers in Hawaii to be part of one of the active clinical trials. These Parkinson patients would not otherwise have the opportunity to participate in these groundbreaking research treatments. Well, Drs. Ross and Borman joined me at the podium so we can present them with the 2018 research grants so they can continue their important work. These are not the real checks, but I had to make up something. Hawaii Pacific Neuroscience. Now I'd like to call Tiloi Lolotai to the podium for a special presentation, please. Come on up here, brother. I think a lot of you know Tiloi. You know that he's had a lot of years of hard work on behalf of himself and those of us in the Hawaii Parkinson community. We've been very fortunate that he took some initiative and stepped forward. This year he made the difficult decision to step down to concentrate on some family matters. So in honor of his numerous years of dedication, we wanted to present him with this certificate of appreciation. Is the representative here yet? Not yet. We have another special presentation that we're gonna make, but our presenter is running a little late, so we'll do that. So what I'm going to do now is I'm going to go ahead and introduce our keynote speaker, and then when the representative gets here, we'll ask if she hasn't really got into her presentation that we take a break and do that, and then we'll go back to hers. And Amy's very gracious and has allowed to let me do that to her. Today's keynote speaker is Professor Amy Lauer. She's a speech-language pathologist and faculty member at the University of Hawaii John A. Burns School of Medicine Department of Communication Sciences and Disorders. Professor Lauer received her Bachelor of Arts in Theater 2003 from Indiana University in Bloomington. She went on to earn her Master's of Science in Speech Language Pathology in 2007 from Portland State University. After graduation, she worked as a speech pathologist at the Center for Speech, Language, and Occupational Therapy and Cook Speech and Language Center, both in California. In 2011, she became manager of the Speech Language Pathology at South Peninsula Hospital, while also being the co-owner and operator of a little local restaurant called Boss Hogg's Restaurant in Homer, Alaska. Pretty interesting combo, but hey, especially you get to learn some local lingo there. Since 2014, Professor Lauer has been the manager of the UH Speech and Hearing Clinic and the clinical director for Department of Communication Science and Disorders at the University of Hawaii John A. Burns School of Medicine. She specializes in voice disorders, motor speech disorders, and clinical methods with special interests in telepractice, clinical service delivery models, and international program development. In 2017, the Communication Science and Disorders Department, under Professor Lauer's direction, won the Best Faculty Engagement Strategy at the Spring Poster Competition sponsored by the Assessment for Curricular Improvement Office at the UH Manoa. Did I get that all right? All that proves is I could actually read what she wrote on for the TV. Ladies and gentlemen, now I present Professor Amy Lauer.
Thank you, everyone. We'll get the slides up. I'm going to get my advancer. Well, thank you all for the honor of letting me be able to come and speak with you this morning and share some time together to share some of my experience and what I have learned along the way working with voice and voice patients of different diagnosis. But I have to say, the people that have touched me in the last decade have been those relationships that I've encountered working with those with Parkinson's. So thank you all for coming and sharing this time. I have to say that you in your resilience are an inspiration, and I hope that, let's go back. Which way am I going? I hope that you'll be able to have some takeaways from today. So we're at the disclosure, so I don't have any financial disclosures. I faculty, as mentioned, at Manoa, and then I'm also an LSVT loud therapist. And in terms of background, I am originally actually from Maine, so I've made it really coast to coast, a couple different ways and directions. I did start in a background of theater and vocal performance at Indiana University, but that's actually where I first started to learn about speech-language pathology and Lee Silverman voice therapy, and that navigated me into a career in speech pathology. Ironically, a few of the faculty that were pivotal in that decision for me are actually here on island. Michael Belknap was my vocal instructor at IU and is at Brigham Young. And Maya Hoover, Dr. Hoover, is at IU, and she wrote my letter of recommendation for graduate school, and she's vocal lead at Manoa. I then graduated from Portland State. At that point, I became LSVT certified as a student because it was my area of specialty and interest. I was always the token person that said, I'm interested in voice. Most people come into speech-language pathology being interested in maybe children working with autism or adults in a hospital, but that's kind of how my passion had led me through, and I guess in ways led me here. Currently, I am at the John A. Burns School of Medicine in the Department of Communication Sciences and Disorders. I would say I have one of the best jobs in the world. I get to work with the master's program. We have a 2-year program that trains students to be speech-language pathologists. It's a fantastic opportunity to work with some exceptional people. Each year we have about 15, 16 students that are coming into the field and are bright and shining and eager and wanting to help and better the world. So that infuses every day that you get to come to work. I work with the students. We're in the UH Speech and Hearing Clinic. They provide services to the community for pediatrics through geriatrics. And then I do teach courses, as was mentioned. So I teach motor speech disorders. There's 4 of our students in the back that I see. They have been taking the course this semester and learning lots about how to care for individuals that do have Parkinson's and help support them. As well as I've taught some other courses related to voice disorders, and as well as like adult neurogenics. We've also started in the clinic some telepractice, which is an interesting opportunity to be able to provide services, speech language services, directly into homes for individuals. So we've been doing that and providing services on Molokai and Big Island, and hope to expand that as well. So this is just a little bit more about the program of communication sciences and disorders. It's a long way to say speech therapy. We have our clinic at the School of Medicine, and there's just some photos of our students and our faculty at work. So today I want to go over a little bit about what is a speech language pathologist. Often the question as we're going through programs or meeting people is people don't really understand what we do as a whole. And so many people, though, are touched by somebody that has had an experience that is connected with a speech language pathologist. Overall, probably the better name would be like a communication therapist rather than a speech language pathologist. If we're going to break speech and language down, language is going to be our understanding and our speaking and our reading and our writing. Voice falls under speech. Speech is going to be the motor mechanical component. So it's how we produce voice, how we articulate, comes into the fluency of our speech. Stuttering may be involved at times with clients. And then we also deal with swallowing as a kind of motor component as well, too. And speech language pathologists, they're from the NICU through home health and hospice. You may encounter working with a speech path. So you see some photos. Let's see, how do I get this one? We have our little ones. The majority of speech pathologists do work with children, probably 50–60% work in the schools, but speech pathologists are also in rehab facilities, hospitals, assisted living facilities, like again, doing home health directly into the homes with both young children and with adults. And then in medical care facilities where they may be doing things like speech and swallowing. And swallowing is a common challenge or issue for those that have Parkinson's. It is not my area of specialty, I will say. I'm more voice-oriented. So that's kind of how I'm going to focus the conversation for today. But it is something that we do extend into. So this is one of my favorite quotes. It's a long quote. We're wordy people. So speech is perhaps the most sophisticated example of a species-wide movement capability in the animal kingdom, requiring split-second sequencing of approximately 100 muscles in the respiratory, laryngeal, and oral movement systems. It's really remarkable what we do as just communicators every day to be able to coordinate our thoughts and articulate them. And with any movement disorder, that fine-tuning split-second sequencing can disrupt that system really easily. And I think that through strategies of rate control and volume and some of the things that we'll talk about, we're able to help improve the coordination of that system. So with that delicate system and having a movement disorder, it's considered about 70–80% of people that have Parkinson's will experience some challenges with voice and speech. I've seen it as high as 89%, and I've also seen that it possibly in time it would be 100%, perhaps, just because of the delicateness of that system. So common symptoms are going to be things like tremors, balance problems, stiffness, slowness of speed. So if we translate any stiffness or slowness of speed into speech, it's going to have an impact, and it's going to affect how all of those articulators move together. So common speech changes that are often experienced are going to be things like reduced loudness. That's probably the most common symptom and common complaint, I guess, of those that have Parkinson's, is that I can't be heard. They ask me to repeat. You may also experience change in your vocal quality. It starts to get more hoarse, more raspy kind of tone, maybe sometimes a little breathy. So at that point, the vocal cords aren't kind of coordinated the same way. And with that, then also imprecise articulation. So that clarity of speech, the power in the articulation is gone because of that amplitude and movement of your tongue and your jaw and so forth isn't the same as it was previously, which can translate into things like unsteady rate, just as there may be difficulties with initiation of movement in walking. The same thing, there can be difficulties with initiation in speech, and then that may kind of group up and because kind of a stutter or a stammer or a stumble and then a pause. So kind of timing overall can be affected. Then monotone. So now instead of having a lot of prosody in our speech, that things become a little bit more flat. We also see that with more of we would call a masked face. The muscles of the face don't move with the same ease as maybe they did before. They're more stiff. And if we think that communication, we know is there's what you say, but it's how you say it that kind of drives the meaning, or all of our nonverbal that we have through our face, our expression, our eyebrows, our eyes, our cheeks, when that's limited or reduced or constrained, it has an effect on those aspects that are the nonverbal aspects of communication that are so vital as well. So what I want to go through is a little bit of kind of how we make speech. This is what I would a lot of times do in a first therapy session. If someone was coming in and had any concerns or complaints, we'd go through and say, I want you to learn about how voice is produced, so you understand how those changes are affecting each aspect of your system. So we have 4 systems that create speech and voice. We have respiration, our breathing. We're going to have phonation, so that's at the level of the vocal cords where we actually produce a sound. And that sound is then shaped as it's resonating through our throat and our mouth and our nasal cavity. And then that sound is broken into pieces by our tongue and our lips and our jaw and our articulators to create sounds in split-second synchronicity. So starting with respiration. I love now we get all of these like 3D models that you can actually understand so much more about what is happening within our body as like technology has advanced. And this is a really great image of the respiration system. And this right here is our diaphragm. You know, I've been studying voice since I was a young girl, and I'd never really conceptualized exactly what a diaphragm looks like. They were always told it's like a little bowl underneath your ribs. And it is not a little bowl. It's actually huge. It extends all the way from the front, all the way back to your spine, and so forth here. And it's a huge arc that connects to your lungs. And when your diaphragm receives a signal from your brain, it lowers. And when it lowers, it kind of pulls the lungs down and allows the air to rush in. So if we think that we have reduced movement, we're going to have reduced movement in our diaphragm. And our diaphragm isn't going to contract and lower with the same amplitude or effort or degree that it did before, which means we don't get as much air into our lungs. We're going to have maybe shorter phrase lengths. You're going to run out of air as you speak. And it happens slowly over time, so sometimes we're not aware of these changes as they occur. But our diaphragm, and if you start to work on breathing exercises, you can actually work on developing the strength of your diaphragm. So we're going to start with a little bit of breathing, and we're going to do some things together. So this is an activity or an exercise I do with a lot of clients that have a difficulty finding a good low breath, because life gets stressful sometimes, and we tend to become shallow breathers. So often I'll tell somebody that I want you to take a deep breath, and they go, and it's all really high and tight. It looks like a Tarzan breath, and their stomach comes in, and their chest gets high and puffy, and they get all of this tension in their throat, and it makes their voice sound even more hoarse. But instead, when we breathe in, our stomach's actually supposed to go out, as it shows in the diagram here. So if air comes in, our stomach actually goes out, and as we breathe out, then the stomach comes back in. But it's probably about like 60-70% of us that actually don't breathe correctly. But if you watch a little baby breathe, they breathe just fine. And they breathe so well that they can cry for hours with really good vocal technique and not get hoarse. But if any of us tried to cry for as long and loud as a baby cries, we'd be hoarse because we don't have as good a technique as they do. They're all natural and, unstressed in their own way, I guess. So what I'm going to have everyone do is I'm going to have you put one hand on your chest and one hand on your stomach. And I'm going to model it first. But I'm going to have you take an easy breath in. It doesn't have to be the big Tarzan breath. I'm going to take an easy breath in. And you want to feel when you breathe in that your stomach is extended out. Your abdominals are used when you breathe. It's not just all the muscles up high. But you're going to take a breath in, and then you're going to exhale on an F, like a for as long as you can, all the way to the end. And don't start quite yet. I hear lots of breathing, which is great. But you're going to exhale that. And at some point, as you exhale, your stomach is going to engage. And you're going to feel those abdominal muscles engage as you get to the end of your breath. And hold it there for just a second, and then relax. And you'll find that as you relax, you'll feel that movement in your lower stomach versus if that high Tarzan breath. So, okay, I see lots of hands in the right place. We'll take an easy breath together. In, and then out on an F. Good. Now keep going all the way to the end. Like you feel those muscles get tight. Try to hold it, and then relax. And you should feel maybe like a little pop in your belly as you inhale in. So we'll do that one more time, just in case you didn't get it the first time. So exhale or inhale in. I'm going to exhale on an F. Let those muscles get tight, 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 tight. Hold it, and then relax. And then you can feel that expansion. Did people feel it in their belly? Excellent. Good. So when you do those exercises, we're kind of pushing it to an extreme in a way. We're really practicing even the range of motion of the abdominals and the diaphragm when you're breathing. So that can help support your respiration. There's also some, I don't have it on the slides later, but there are some tools now that are starting to be used for people that are experiencing difficulty with respiration, similar to what they do with sometimes athletic training, where they actually have like resistance, where you would blow or breathe in through a device that with that resistance will help kind of exercise the diaphragm. And I think that they're really starting to develop more research with that too to see the efficacy of it. So then after we get that breath and we get that good air within our lungs, that air is going to travel up and it's going to hit our vocal cords. And this is a really good image, I think, of our vocal tract. I'm going to go this way. This area over here is right where our larynx is. Those lines of the green kind of mark the larynx. And if you guys all just hold on your neck and kind of find where you would feel your Adam's apple, that it would be your thyroid cartilage. And that's your shield. That's there to protect your vocal cords. And right behind that are two vocal cords that lay across here at this, right here. So and as the air travels up through the trachea, it passes over the vocal cords. And when it does that, they vibrate and they create a sound wave that then will travel up through the oral cavity and the nasal cavity. Kind of gives us our fingerprint of our sound. And our vocal cords on this side here, so this is kind of looking as though we were looking from the top down. When we breathe, our vocal cords are open. And then when we go to speak or to sing or to hold a tone, then our vocal cords come together to create that sound, and they vibrate. And then it's kind of like a guitar string. When they're together and they're thicker, our pitch is lower. And then as they stretch and they get thinner and tighter, then the pitch goes up. So we actually control pitch at the level of the vocal cords. So on the next slide, we're gonna watch a little bit of a video that's a stroboscopy video of how an ENT would go and visualize the vocal cords. And I think it is another way to kind of get an idea of how all of this anatomy works together. But before I do that, just to kind of note, as I was saying, those changes in amplitude or degree and range of motion that you might experience with Parkinson's and what that looks like. This right here is with them all together, as they come together. If they don't come together all the way with a good closure, sometimes there'll be kind of a gap right here, which means air passes through. So instead of it being maybe a nice sounding like ah, it gets to be ah, because air is escaping out of the gap right there. Also, the vocal cords can kind of start vibrating at 2 different rates because they're not synced as well. And at that point, we get what we would hear as hoarseness. So that ah can turn to ah, not as pretty. But it's because of reduced drive to these muscles that bring these vocal cords together. Hold on, I gotta run over and press play. For show of hands, how many people have had the stroboscopy done? You get a camera that goes through your nose? A couple, yeah. So at this point, they're going through the nose. You can kind of see as it passes, it's gonna stop at the top of the soft palate. You can see how it moves there. And then the camera's gonna pass over the soft palate and look down. Oh. Yeah, so those are the vocal cords, kind of like the image on the previous slide. And then as she comes down, they kind of get closer together and thicker. When they turn that strobe light on, you can actually see like individual movement of the vocal folds. You need the stroboscopy because they're moving at like 200 times a second. So I'm going to go back to the previous slide for just a moment. So the camera then was coming through here and then looked at the soft palate. We're going to have another video that kind of shows a little bit more about the movement of the soft palate. And then the camera came and turned down and then was able to look right at the top of the vocal folds there. So you can see how that kind of anatomy works and how if there is reduced drive or movement in those vocal folds as they come together, you're going to have a change in vocal quality, which is a lot of times one of even some of the first symptoms that people start to experience with Parkinson's, just because of the delicateness of the system. You have these 2 delicate, small little muscles. So when you have that movement impacted, it does translate into a change of speech and voice. No, it doesn't like me. Okay, I'm back. So next is that level of articulation and resonance, and I kind of group these two together. So that if we go through, we got our breath with our respiration, our diaphragm went down, our air came into our lungs, it travels up, it passes over the vocal cords. It's going to make those vocal cords vibrate. As you heard on that last video, it was just open ahs. Ah, there wasn't any sound or there wasn't any words to it. But as that comes up and it passes through, it's shaped by our articulators. So our tongue and our lips and our jaw, it touches our teeth, as well as our heart and our soft palate. And I like this image. There's a lot going on this image. But what it shows you is kind of how our sounds are grouped together. Because often as people will start to misarticulate sounds. Maybe you say a sound a little bit different. It can change the word, changes the meaning of what you were just saying. But it's because so many sounds are so close together. So up here, we have these sounds. You have t, d, s, z, ch, j, n, l. All produced with the tip of your tongue right behind your front teeth. And just a little change in the timing of that, or how much pressure you push, or how much air passes through can change. So it's all in that split-second timing of a single sound. So I'm going to have you guys all do that because I want you to feel kind of within your mouth where these different sounds are. So I'm going to have you come up, and I'll say them one more time. This one's ch, and then this one's j, like in judge. And this one's like ch, as in chip. So the other ones are pretty self-explanatory. But if we do them together, I'll do it one more time. So t, d, s, z, ch, ch, n, l. So now we'll do it. So t, d, t, s, ch, ch, n, l. So you can see how much is just with the tip of the tongue. Then we have other sounds that are back sounds. We have like a k and a g made with the back of our tongue. We have a h, which is just made by those vocal cords coming together just slightly. We have our lip sounds, our p, b, and and all of those, if we think about putting together a sentence of how much is connected at one time, it's quite remarkable that we can communicate as well as we do. So the next video I'm going to share with you is actually an MRI image or video. Again, this is what is really cool about science these days, is that you get to see all these different ways of viewing and understanding the body. This is one, it's actually from a singer, so you'll get a little bit of song at the end of it, but goes through and describes where the structures are. One thing that always amazes me is how big the tongue is. We think about, as we just even did that, just with the tip of our tongue in our front. But the tongue is huge. It connects down to the top of our larynx at the hyoid bone, and you'll see how much movement is involved with that in the video, as well as the movement of the soft palate. I didn't mention in the last slide, but in terms of resonance, how air passes through the oral cavity and nasal cavity kind of affects the quality of our sound if it sounds nasally. If there's weakness in the soft palate, you're going to have more air passing into the nasal cavity, which can also kind of change the quality of a voice. One is you saw how much movement there was in the tongue. The tongue's sitting there shaping all the time. The tongue is really important not only for all those sounds that we practice, but for our vowels, because it is a very small change between an E and an A and an A and an O. That's a really slight movement. So if you do have impaired difficulty or have difficulty with coordinating your tongue, you may find that sometimes the vowels don't come out exactly like you were expecting because it is a subtle adjustment for those. The other thing you saw in his different kind of styles, some he would really open his mouth wider. And that is common, as well as that as there's the sensory component with Parkinson's where you don't have as much kind of sensory feedback, that proprioception of where your body is in space. Same thing happens with your jaw and your tongue. You feel like you're opening your mouth a lot and you're articulating really clearly, but you've really kind of just narrowed the opening and it's not very clear and may start to become mumbled. So you can think about trying to do your rock mix, I guess, and trying to keep the mouth nice and wide and open. So this is actually a good break point. So I'm just going to pause.
All right. Thanks, Amy, for letting me bother you. Like I mentioned earlier, we do have a special presentation today. And so if the Hawaii Parkinson Association officers would please join me at the board, Lindsay, Kay, and Dennis. First, today I want to introduce a very special guest for this presentation. Representative Jarrett Keokaheloi, how bad did I do? Is a proud 7th generation resident of the 48th House District, including Kaneohe, Ea, Ahui Manu, Kahalu, Wahe, Kali, and Waihole. Elected to office in 2014, he is currently the vice chair of the Committee on Labor and Public Employment and also serves on Finance, Transportation, and Public Safety committees. Today he is, let me back up. Representative attended public school in Kaneohe before graduating from St. Louis School and holds a BA in journalism from the UH Manoa and a JD from the William S. Richardson School of Law at the University of Hawaii with a certificate in Native Hawaiian law. Today he is presenting the Hawaiian Parkinson Association on behalf of the entire Hawaii Parkinson community, a proclamation signed by Governor Ige and Lieutenant Governor Chin declaring April to be Parkinson Awareness Month in Hawaii. Representative, thank you for taking time from your busy schedule to be here and making the presentation. With that, over to you for a couple quick remarks.
Good morning, aloha. I'd first like to start off by thanking Jerry for having me. I met Jerry actually because he lives in my district, and I knocked on his door at his house when I was running for office, and we talked for a little bit about, I think it was the military, and he was actually the first person I messaged on Facebook when the guy pressed the button and the missile was in. I'm just kidding. I messaged him after to find out what happened, but I'm really thankful and honored to be here to present this proclamation to you folks in your community, and really happy that Jerry invited me to make some remarks. So I've prepared a couple of hours worth of remarks that I'm gonna save for later. I'd just like to just real quickly say that I'm happy to be here with you folks, and Jerry and I spoke before the legislative session about sort of the long-term plans of the organization, and I'm really happy and excited to play a part in that. Parkinson's is a condition that I think has national prominence because of the national celebrities and sports figures and people who have suffered from the condition. But what happens often in Hawaii is what you see on TV is not necessarily what people feel over here. And in Hawaii, we do have folks, there's a large population of individuals who do have Parkinson's here. And so research and awareness and access to care are issues that we need to deal with. And the legislature in particular is best suited to serve a support role in these types of initiatives. So it's really great that you folks are up and running, that you're organized, that there's a large support community, because when the advocates come in to the legislature and push for initiatives that really make a difference, that's the most effective way to move an issue forward in the state of Hawaii, particularly in our state government system. It really does have to be community driven and community designed, because that's the only way you're really gonna have effective, move the ball forward effectively for the community. So I'm at my best when I'm playing a support role. You folks are well organized, you have a plan, things are moving in the right direction. So I'm just really happy to be here to let you folks know that there are folks at the state level who support your community, who want to help, and are here for your support. So on behalf of the Hawaii State Legislature, it is my distinct pleasure to honor the Hawaii Parkinson's Association, congratulate you folks for a successful symposium, and declare April Parkinson's Disease Awareness Month. Thank you very much.
Before I turn back over to Amy, I was remiss. There was a couple of admin notes that I was supposed to make. The first one was on the restrooms. Something very near and dear when we take a break. There's restrooms over by the security office, down that direction, off of Center Court. And I'm trying to remember where I think they told me where the rest of them are. That's all I can remember right off. Second, Cocoa Communications is going to be emailing a post-event survey to everybody who registered for the event. Please help us make the symposium better and stronger every year by giving us good feedback. For those who have a burning desire to make a comment right now, there are comment cards at the HPA table out in Center Court. Feel free to stop by and jot down your thoughts. Dr. Lucas Morgan is going to be talking at the Hawaii Kai Caregivers Support Group on June 9th. I think he's coming in from quite a ways, University of Massachusetts, Boston. If you have more questions, Pat Bemis or the Hawaii Kai folks can help you out. And there's flyers out on our table. Those are open to anybody. And lastly, the Hawaii Parkinson Association is an all-volunteer organization. Donations and volunteers are our lifeblood. We are currently looking for volunteers to fill several important positions. If you're interested in helping out the Hawaii Parkinson community, not just HPA, but the community itself, please stop by our HPA table for more information and to fill out volunteer applications. I think that's the last admin remark. So with that, I'll turn it back over to Amy. Thanks for your time, folks.
Okay, well, the next section I'm going to talk a little bit more specifically about, we kind of talked about what the anatomy is and what you might experience across those different parts of the anatomy. But now I'd like to talk a little bit about what kind of interventions are available to help support if you're having any changes in speech or voice. I kind of broke it down into two general categories of mild to moderate and then moderate to severe, kind of depending on considerations. But it's very individualized. I think everyone has had their own experience with Parkinson's that is similar but unlike anyone else's experience with Parkinson's. And I think that that's part of what we do as clinicians, is try to learn about the individuals that we are treating to really determine what would be the best approach. So probably our gold standard is the Lee Silverman voice therapy, which I imagine many of you have heard about, have been familiar with. How many have gone through the program? I see one, two, a show of a few hands, maybe about a half dozen to a dozen, so that's excellent. Where I say it's mild to moderate, some people benefit from the program at any time. They do recommend starting it early, so you're learning the foundation. You're learning really the exercise behind keeping your voice healthy. Parkinson's responds to exercise, and we see that through the LSVT BIG program, where they work with gait and walking and movement, and it is neuroprotective. And that's one of the reasons that I have taken such a joy to working with clients with Parkinson's, is because there is improvement. And it's wonderful to see when there's been a progression of decline. To have an opportunity to work with somebody and help them get their voice back is probably one of the most rewarding things that I can do. So LSVT has been researched for almost 30 years now. They Dr. Ramig and Dr. Cynthia Fox have been committed in their research to supporting the best practice for those that have Parkinson's. It is delivered by speech-language pathologists. You have to be trained and certified by them to provide the therapy. We were fortunate this past year in January that Dr. Fox came and did a training on Island. I went through the training again, as well as 4 of our students in the back, as in a number of our other students too, were able to go through that training and become certified. And kind of the nature of the program is we went through all of those complex stages. I gave you a lot of information. I've said, this does this at the vocal cord level, and this is how you breathe, and this is how the sounds are broken up, and it's a lot of information. So I apologize if I overwhelmed anyone. But the LSVT program tries to bring that down to something that is a little bit more simple to remember and accomplish the same task. And with that they really focus around a concept of thinking loud and being loud. Because when you fuel up to be loud, you're going to take a deeper breath. You're going to put more effort in getting those vocal cords together. And you find that you actually articulate more and you open your mouth more. All of those things you want to do simply by just thinking loud and trying to be loud. The program is prescribed. It is 16 sessions, usually delivered across 4 weeks. So there's an intensity to it, but that's on purpose. It comes from a background, and a lot of the research is rooted in principles of neuroplasticity, in principles of exercise, of saying how much exercise do you need to do to make change and maintain change. So that's where that dosage of 16 sessions in 4 weeks comes. Across those sessions, you have your daily exercises that you learn to do. And they are going to be things like sustaining an ah for as long as you can. You do things like highs and lows. So you're going to glide to your highest note. You're going to go down to your lowest note. So if you think back to that voice video that we watched, those vocal cords were stretching when they got higher and they were contracting as they got lower. So doing highs and lows is kind of like putting weights on your vocal cords and going to the gym and giving them a workout and doing range of motion and strengthening. And then there's parts that are phrases. And this is kind of comes into this calibration part of the system. They recognize that you can come into our clinic and we can give you cues and we can tell you to be loud and you can be louder. But unless we make that meaningful for you, you're gonna stop being loud when you get to your car in the parking lot. And that's what had happened a lot of times. And speech therapy for a period of time was not considered effective until they found that you have to practice to where it's no longer performance, but it is a learned behavior that is calibrated into your system. And you can recognize that sensory difference. So this visual right here is one that we commonly use. I keep not figuring out how I should stand. I apologize. And that I said that Parkinson's is progressive. So the changes that you experience happen slowly and sometimes insidiously over time. And you don't realize, perhaps, that you're softer than you used to be. You think everyone else needs a hearing aid. But instead, you have just kind of slowly, in that like shrinking disease, kind of gotten quieter and softer. So you might be speaking here, but you feel like you're in normal loudness. But you might be soft, or you might be very soft. So we want to program you up so that you think loud just so you can get to normal loudness. And then you're going to practice that routinely so then it becomes second nature to you. It's new motor memory. Then we have those phrases. We have functional phrases. We're going to have you as clients come up with phrases, things that you say every day. What are we having for dinner? Maybe you have a dog and you're going to say, Spot, come over here. These things that become triggers for you and reminders in your day to say, that's one of my think loud phrases, and I'm going to be loud. And then we go through exercises to where we build up on sentences and reading and conversation. So by the end of the 4 weeks, you're able to support an hour-long, strong, loud conversation and be able to carry that over into your daily life. So in terms of that neuroplasticity, some of the programs really built around these concepts of intensity. So that's why it's that intensity of the number of sessions. It's the intensity of the repetitions. You have 15 ahs you have to do, and 15 highs, and 15 lows. And then that saliency piece of making it meaningful and making it relevant and making it personal to you. So one of the first clients that I worked with was in California at the time that had Parkinson's, and He was great. He was this older Italian guy. He kind of seemed like he should be out of The Sopranos. And he had stopped playing bocce ball. That was one thing. He always had this group of guys, and he would go on Thursdays, and he'd play bocce. But because he was having a hard time, it was outside, his voice didn't carry as the same way, he had stopped attending bocce. So when he came in, that was one of his personal goals. So some of the things we used on phrases and activities were all related around his interests. And I know it was probably about the third week we started giving him homework, and his homework was, you need to go play bocce with your buddies. And he did, and you see in those moments, they kind of become these light moments where that connection and the quality of life and the meaning kind of comes back. So it is very unique, and that saliency piece becomes very important. So I imagine a lot of you guys have met Shirley before. She's a client that went through the LSVT program, and I probably watched her probably like 60 times across time, and it still doesn't get old. So even if you've seen it before, you'll still enjoy it. But I think she kind of shares and embodies a lot of what we talk about with LSVT. So hold on. So Shirley always has a way to kind of reach out and connect with the group. But you hear the change in her voice. It went from being very quiet, you heard the hoarseness, the more monotone with it. And then after treatment, she's loud, she's got good quality. That went for probably 20 seconds or so with it. And you also hear that rise and fall in her voice. She has a little giggle that she throws in, and the pitch change that makes it personal. And then you also see, I think, most prominently is the change in her affect and her disposition. Voice and communication is so connected to quality of life. We are social beings, and we need those connections to be able to have that light. And you see with her, and as she shares about some of her situations, of what kind of joy that was bringing back for her too. Okay, we're good. So some other considerations. So, well, LSVT, like I said, is a gold standard, and it's a hallmark, and I strongly recommend to anyone that hasn't participated in the program to try to locate an LSVT provider. It's not a hard program, ahs and highs and lows, but it's intense. And that intensity, like I said, is there for a purpose. And I know a lot of people will say, oh, I can do that at home. And yes, you can, but we all can use a coach sometimes, and particularly when things are hard and things are difficult. It's just like if you were to go to the gym, having somebody there that can give you skilled instruction can help shape the sound and can help encourage you and motivate you as you're starting to learn and habituate these things. Strategies back into your system are really important. So we provide the service at our clinic, but there are LSVT certified providers in the islands. So if you do go to their website at LSVT Global, you're able to find clinicians for both the LOUD program as well as the LSVT Big. So other strategies that we can have in terms of assisting in communication are going to be some things of like speaker and partner strategies. Just checking time. Okay, so some of the things we want to think about as a speaker is that, and these are just good communication techniques. One is preparing your partner and maybe setting the topic. We've all had that situation where somebody starts talking about something that you don't even know what the topic is and how much time it takes you to start thinking about the context until you understand what the relevancy of this comment or topic is. So the more you can say, I want to be able to talk about what we need to get at the grocery store, instead of just saying chicken noodle soup or something like that, it gives the reference for the communication partner to better understand where you're coming from. Use of gestures can be very important. So just as there's that reduced amplitude in walking and in speaking, we also find that people stop using their hands and their gestures as much. And there is so much that we can communicate by using gestures. Sometimes we work with our clients that have had a stroke or have aphasia, specifically of just trying to use gestures to be able to support their communication. So those are strategies that can be helpful. Sometimes having turn maintenance signals is helpful, and this is where I think sometimes a speech language pathologist is helpful in kind of navigating these partner strategies with a patient and their family or their caregiver. But sometimes you need a little extra time to collect your thoughts, think of a word, get through a phrase, and sometimes you just need a socially appropriate way to say, I need a few more minutes. But if you stick your hand up to somebody and they're not ready for it, they might not read that the same way. So having a discussion of saying, how am I gonna let you know that I need a little bit more time to speak? Or when do I need help finishing my sentence? Because we want people to be independent. So having an open dialogue about that is sometimes helpful. Timing important communication changes. We fatigue during the day. And we also have differences when you're on medications. You have times that your communication's gonna be stronger or weaker or poorer. So being considerate about if you have important conversations to have with doctors or families or loved ones, to think about when that's gonna happen during the day, so you're making sure you're doing it at a time when you're best to communicate. And then also selecting your environment. So that can be from thinking about sound level. So which restaurant are we gonna go to tonight? Having considerations of one that has good acoustics. Even positioning yourself, talking across the room, talking across the house, or are you gonna position yourself at the table or in the living room so you're face to face or side by side? Even good lighting. We get a lot of cues from reading lips and looking at faces. So making sure that you have an environment that's really optimal to be communicating back and forth, really helpful. In terms from the listening side, so the partner strategies, one, just you can help with all of the things the speaker needs to do. Stopping and trying to get topic maintenance, helping adjust the environment, turning off the air conditioner if you need to help you hear the other person better can be helpful. Maintaining topic. Sometimes conversation flows, you know? But if you have somebody that's trying to express a thought and it's taking them a little bit longer, sometimes people will just jump off to the next topic. So being cognizant of holding on to your next thought until your speaker has finished theirs. Just simply paying attention to the speaker, looking eye to eye, face to face, making sure your body's positioned, your head's not in a magazine, you're not washing the dishes. You've stopped to be able to look at that partner and be able to understand as best as you can what they're gonna say. And then just doing your best to piece things together and manage any breakdowns. And then some strategies for as the disease may progress. The benefits of the LSVT can still be there, but it may be harder and harder to execute over time. So some things you may look are more supportive, where I would say the exercise approach would be more restorative. Then we look at supports of how can we support speech. If you're still, even with your best effort, not able to communicate as loudly or as clearly as you would like. We now have like the wireless voice amplifiers. These have gotten so much better in the last like 5 to 10 years, and also much cheaper. You know, you can get a wireless Bluetooth one for like $60 on Amazon. And there's a variety of headsets. I know a lot of people say, I don't want to look like somebody that works in a call center. So you can get a lapel mic and so forth. And then these just can clip on a wheelchair, they can clip on a walker, they can clip on a belt buckle. And then you can adjust just the volume. So if you're having difficulty achieving the volume that you need, then using some sort of amplification device can be really helpful. Then also there are considerations of rate control. So Shirley mentioned that sometimes she stammers, so she'll stumble on her words. by working on slowing your rate, a lot of times, one, it gives your mouth more time to coordinate all those movements that need to be coordinated for speech. So there's two ways you can use a simple alphabet board. You can just put the alphabet on a Word doc and print it out. It's nothing really special, but it can be really effective. One way is just for you to point to the first letter of each word you say. So for example, here, if I was saying rainbow, I'd point to the R. And then if I was to say a phrase, maybe I'd say, today we are at the Parkinson's Symposium. So that first letter that is cued can be really helpful for the speaker to understand if there is any misarticulation. You gave them a really big cue by letting them know what word or what letter that word started with. It also, as I did it, it slows me down. So that's why it's in kind of a moderate to severe category. A lot of times we'd want to talk more fluidly, and if you can, that's great. But if you're managing communication breakdowns or having more difficulty, just to say, try it again, say it again, and it's still not clear, this can be a really good tool. Some clients may get to a point where they have to actually spell words, but often that's not the case for individuals with Parkinson's. It would just be a support for clarity. Other things that can be helpful strategies for supporting in communication. The previous slides talked about considerations of topics and topic maintenance. So sometimes having a set of topics of interest or common topics can be a way of framing those conversations. This is particularly helpful too if there's any related dementia that may have progressed, of having visuals to be able to support not only communication but cognition and memory can be very valuable. And what I have here, this is from a study that I learned about recently. It was actually a study conducted by a set of doctors out of Oregon, and they were looking at developing what we call AAC, or assisted communication systems, for individuals with dementia. And they were saying, well, what are the things that people want to talk about? So often these communication boards just have food and clothing and, things that are daily necessities, but they're not what we want to talk about. We don't have conversations about our socks, but it turns into, I need socks and I need a drink, so often on these communication boards. So this study was trying to say, what do people really want to talk about? And they had 109 participants generate topics, and then they grouped all these topics under 9 categories. And these were the 9 categories that people were interested in most discussing. So from hobbies, family, travel, work and home, sports, religion, animals, and World War II was a topic with the group they had. So I take this in a couple ways. It could be something where maybe some point you're thinking about topics of a conversation board. But I also think I've had so many times in my work where I've had to walk in and you get trapped in the phrase of how are you today? How are you doing? It sometimes can be a loaded question because not all days are good. And we say in LSVT, well, you got to be loud even on your bad days, so let's get to work. But there's also an aspect of saying, how can I reach out and connect? I think this becomes hard with social circles too. Not everybody knows how to communicate when somebody's communication changes. It becomes sometimes different, or different becomes uncomfortable, and what are we going to talk about that we're going to be able to connect with? So thinking about these things, these are universal almost. These are things that everybody wants to talk about, their personal hobbies. Maybe it's woodworking, maybe it's bocce ball, for sports and so forth. So this is some of what we try to find out about our clients, but it's something that you as caregivers or family members can think about when you're coming and trying to communicate good things that you can think about connecting on. So I leave just with a couple of quotes. So one, communication is the essence of human life. There's a lot that is in human life. I'm not sure it was written by a speech language pathologist, but I do agree. And it is essential to us, and it is a huge part of our happiness and our well-being. And that communication works for those who work at it. It is something that even as children, it is work to learn how to speak. It is, and learn how to communicate. And we can spend our whole life working on being a better communicator. And I don't know that that happens or changes for really any of us. But those that have Parkinson's have kind of a little bit more of an uphill battle to maintain that. And it is work. But the work pays off, and the work can benefit to help support and maintain that communication, maintain those relationships. And I guess in that, keep connected. So thank you for the time that you were sharing. And if you have questions, I'll be available around as well as on the panel later. So thank you.
Well, thank you, Professor Lauer. What we heard was definitely today breathing, communicating, and human connectivity are really the essence of human resiliency, internal and external connections. And so what I, as a board member, again, my name is Lindsay. Hi, everybody. As a board member today, we are going to do some breathing, and Professor Lauer warmed us up a little bit. I am a yoga therapist, and my PhD is in social science, and so my focus is on human connectivity as well. For the Hawaii Parkinson's Association, we would like to know from all of you how we can better provide health and wellness resources, as well as perhaps classes. And so please come to the table over in the center court area to give us some information and feedback. Before we stand up to leave, what we're going to do is take our right hand. We're going to take our thumb and place our thumb over our right nose, our nostril. We're going to take our ring finger and pinky and place it over our left. Now, don't totally close your nose. I do want you to breathe. Okay, we are going to start, though, breathing in with our left nostril, and so you are going to close your right. Inhale. Close the left nostril and open the right and breathe out. Breathe in your right nostril. Close your right nostril. Breathe out your left. We'll do it again in just a second, but let me tell you what that is. Nadi Shodhana. It is Sanskrit for alternate nostril breathing. And because we've heard so much great information, this is a great breath not only to integrate the right and left brain, this is also a breath that works to do a variety of things. It is very balancing for our bodies. It does create internal and external connections and awareness. It helps us breathe more deeply and use what is a transversus abdominis thoracic diaphragmatic breath, that deep breath that Professor Lauer taught us. And it absolutely helps to just bring information into our body and settle us. Okay, so we'll do it again. Right thumb on right nostril. Let's close the right nostril. Inhale through our left. Close the left. Exhale through the right. Breathe in through our right. Close the right. Breathe out through the left. We're going to do it 2 more times. And as you inhale through your left, you can close your eyes. Close the left, breathe out right. And begin to focus on the heart. Breathing in through the right. Close the nose, breathe out through the left. And as you focus on the heart, breathing in through the left, feel a sensation that is regenerative, breathing out. Joy, compassion, breathing in. Closing the right and exhaling left. And allowing the hands to come down to our sides or our laps. And with that joy, compassion, whichever it was the regenerative feeling that y'all were focusing on from the heart, See if you can't just let that expand maybe 2 or 3 inches outward. And say to yourselves, or we could say it out loud in our mind, I am, and then whatever that feeling was. I am joy. Thank you all so much. Please enjoy what we have to offer today in Center Court during our break, and then we will reassemble for our panel at 10:45 for our panel Q&A.